Well, welcome everyone to our Sign Out with the Professor session today. I'm very pleased to introduce our guest professor who's with us today. And as a bit of background, Dr. Wenyi Luo graduated from Peking University in Beijing with his doctoral degree in 2004. Subsequently, he came to the United States and obtained a PhD in genetics at the University of Alabama, Birmingham. We were very fortunate to be able to recruit him to come to our residency program following that. And he joined us here for 4 years of training in pathology, after which he did a fellowship in GI and liver pathology at the MD Anderson Cancer Center in Houston, Texas. He has since returned to our faculty as an assistant professor and is focusing on GI diseases and GU diseases, doing a considerable amount of collaborative and translational research with other investigators on our campus. And so it's my pleasure to introduce him, and I'll stop the share so he can share his great cases that he has prepared for us today. As we go along, if you have questions, please feel free to type them into the chat box, and that will enable us to cover those questions at the end.
Hello, everyone. Thank you for the introduction. I cannot pretend I'm the professor, but let's just view it as like an informal discussion. You guys probably have more experience than me, So let's just, regard this as an informal discussion or kind of a tumor board. Just feel free to raise any questions. The topic I picked today is neuroendocrine neoplasm, because I feel that these kind of tumors are very confusing. The classification, the treatment effect, the morphology, and there are also a lot of mimickers. They can have neuroendocrine markers, but without any, clinical or diagnostic or prognostic significance. So that's why I picked this topic. So today we're going to look at a whole spectrum of these tumors, from true neuroendocrine tumor to neuroendocrine mimickers. Hopefully you can get something out of that. We don't easily fall into the trap. So here's the first one. Can you see my screen? Yeah. Okay. So every case has a story. There's a story behind that, because one day in the morning, my resident break into my office and told me, "Oh, I found an interesting case. This case has a lot of plasma cells." I instantly recognized that that's definitely probably not plasma cells. We can have plasma cell neoplasm, but most likely we're having a tumor with morphology similar to plasma cells. That is neuroendocrine tumor. That's what I took from what she said. And this is that biopsy. Obviously, it's a very, very bloody biopsy. We can see some of these, normal fragmented, normal pancreatic parenchyma. However, we also see some of these hyalinized stroma. Not much cells, but just the hyalinization. All these are already, raise a possibility of neuroendocrine tumor, because these kind of stroma are very common in neuroendocrine tumor, although not entirely specific. Here are also neuroendocrine tumors. In the texture cells, not much to say. It might be some smaller cells. You can say they are somewhat plasmacytoid. That's it. But when you look at the floating cells, there are lots of these floating cells. They are somewhat plasmacytoid. But different from plasma cells, they're not that discohesive. Some of them are forming these clusters. Very bland appearance. There's no mitosis. There's no necrosis, whatever those high-grade features. So this is a classical picture of a neuroendocrine tumor. As we expected, pancytokeratin is totally diffusely positive. Streptofycin is diffusely positive in these so-called plasmacytoid cells. So this is a classical example of a well-differentiated neuroendocrine tumor in the pancreas. And this is a very small tumor, 1.2 centimeter tumor in a 37-year-old female. So It doesn't have to be resected. It can be monitored or surveyed because it's less than 2 centimeters. So this is a second case. This is a big tumor, 18 centimeter in a big mass in a 69-year-old male. And it was resected 80 years ago. Actually, the clinician asked me to review it because, it was diagnosed something pretty malignant, but, it seems like it never recurred or something. So this is the tumor. It's pretty big. And in some area, it has that diffuse growth pattern, but in some area, it's pretty nasty. And we go to higher power. Again, we see these hyalinized stroma. Hyalinized stroma, nasty tumor cells, very bloody background and out of vessels. When we go to higher power, these cells, somewhat signaling cell-like, some of them are binucleated and trinucleated, very ugly, very pleomorphic. It seems to be somewhat discohesive, kind of reside in the clear space. This can be easily diagnosed as signaling cell carcinoma, right? Or some rhabdoid carcinoma. Of course, melanoma should be in the differential diagnosis. But don't forget that every nested, when we deal with tumor with nested morphology, the neuroendocrine tumor is always in the differential diagnosis. So this one we did the synaptophysin. Not surprisingly, it's diffusely positive. So based on the original pathologist did do synaptophysin. So it was diagnosed as neuroendocrine carcinoma based on the ugly cytology, right? But when you look at it more carefully, these cells, although are pretty ugly, they don't have many mitosis. They're pleomorphic, but they don't have many mitosis. So I did a Ki-67. That is pretty low, actually. It's probably less than 3%. It's in the range of neuroendocrine tumor. So based on that, the diagnosis is a neuroendocrine tumor, probably pleomorphic variant. There are some publications regarding so-called rhabdoid morphology, neuroendocrine tumor with rhabdoid morphology. They said, oh, that those tumors are kind of aggressive, whatever, but there is no follow-up studies. So it's still controversial whether the so-called pleomorphic or the neuroendocrine tumors with plasmacytoid with rhabdoid morphology actually have poor prognosis. Right now, this morphology does not have prognostic or diagnostic indication. And this one I also did CDX2. That is weakly positive, suggestive of gastrointestinal primary. So this patient does not have any tumor anywhere else. This is primary neuroendocrine tumor of the liver. That is super rare. Now the concept is that this tumor is not arising from liver cells. It's probably arising from the bile duct because we can see, very, very rarely you can see some normal neuroendocrine cells in the biliary tract. This is probably one of those rare cases. So we all know that neuroendocrine neoplasm can have, random pleomorphism. They don't have much, prognostic diagnostic indications, including neuroendocrine tumor, including the adrenocortical adenoma. Sometimes you can see these, pleomorphic cells, unless it is, extraordinary in the adrenocortical adenoma. It usually doesn't mean too much in the neuroendocrine field. So third case, again, this pancreatic tumor is very, very, very subscribed. This is definitely normal pancreatic parenchyma, and here we get let's look at the history. I said there's a 2.3 centimeter very circumscribed mass in a 66-year-old female. This is already set up the scenario for neuroendocrine tumor, and it does look like that, right? At lower power, it's very, very, very circumscribed, and there we do have these, nested cells. And they are somewhat, semi-discohesive. Some are very cohesive. In some area, it might be slightly discohesive. The stroma is also hyalinized. Very vessel rich. This is already set up for neuroendocrine tumor. This is consistent with neuroendocrine tumor. Synaptophysin, penicillin, all positive. Nothing surprising for that. We have these area said, all the neuroendocrine cells are detached with only the stroma, is kind of corresponding to the first case we saw. However, what's concerning on these components, I don't know whether you guys previewed it or not, these components, ductal components, they're pretty angulated, pretty anosmosing, right? And some of them even have these luminal neuroendocrine cells. So I guess the question, we should ask is whether this is benign component or malignant, whether this represent a malignant, mixed tumor with ductal component and neuroendocrine component. That's a major question. So what do you guys think? This case also has a story because it bear a malignant diagnosis. It's diagnosed as mixed PDAC and the neuroendocrine tumor. But actually, when you look at these ductal components, they are benign. Actually, they are anosmosing. That's for sure. And architecturally, that's definitely wrong. But when you look at the cytology, they are all uniform. They are all uniform, and they don't have any malignant morphology. They don't have mitosis. They don't have necrosis, whatever. Some of them are close to big vessel, though. That is based on whatever we learn. We have a duct in pancreas that is very close to vessel. We should consider it possible tumor. However, when you look at all cytology, there's nothing concerning. They are very uniform. They're very bland looking. Actually, somebody did a study on these kind of tumors. They dissected all the ductal component. They did all the mutation analysis. There's nothing. There's no KRAS mutation that is present in over 90% of the PDAC. And when the tumor becomes metastatic, they don't. When the tumor becomes metastatic, only the neuroendocrine tumor component will be metastatic. These ductal components never metastasize. So this is not a mixed tumor. It's a neuroendocrine tumor. These ducts are just considered as entrapped duct, reactive ducts. Some of them even consider this as a transformation of acinar to ducts because some of them does have the granular cytoplasm. So, and another clue that all these components are kind of confined within the territory of neuroendocrine tumor. They don't go outside. All the clues of these ducts are not malignant. However, some of the cases were indeed diagnosed as malignant tumor. So this is essentially when the paper was published, it was called neuroendocrine tumor ductal insular type because these are ductal type, these are insular type, ductal insular type. And some of these ducts, by the way, also express neuroendocrine markers. So some people call it ductal insular type neuroendocrine tumor, but don't put that in the diagnosis. We don't call that neuroendocrine tumor ductal insular type because clinicians don't know what that means, don't know how to treat the patient. We just call that neuroendocrine tumor, then we grade it based on the neuroendocrine components. In the comment, we probably can mention there are some, ductal component, there's some benign ducts, entrapped ducts, and the proliferation ducts inside the neuroendocrine tumor, but that's not considered as PDAC components. So that's a major take on for this case. Do not diagnose these kind of tumors as a malignant tumor. The reason that it becomes so kind of pseudo-infiltrated is because of the hyalinized stroma. Because these stromas kind of squeeze and stretch all these glands, make it more, pseudo-infiltrated. This is the fourth case is an interesting case too because it's a pretty young female, with some interesting history that kind of already suggests of something that we should consider. There are two mass, 2.8 and 2.0 centimeter. Solid mass and also a cystic mass, smaller cystic mass, 1.1 centimeter. And this is a solid mass. Again, we're talking about neuroendocrine tumor. You will go there, directly. But in the practice, especially with all this history, we probably want to think more like differential diagnosis. It's a very circumscribed tumor, and the tumor cells are again a nested morphology with all these stacked horn vessels. When you go to higher power, they are very somewhat uniform, right? It's very nested morphology with chicken wire vessels wrapping almost every nest. A lot of nests of these tumors, and the tumors have this characteristic almost bubbly cytoplasm, or you can call it microvesicular steatosis like cytoplasm, right? or adrenal cortical like cytoplasma. All these should be in the differential diagnosis, right? If I tell you that the patient has a renal cell carcinoma, has a big tumor, renal mass, and on top of that, we have this tumor, and it is pan-cytokeratin positive, and it also is PAX8 positive. Isn't that very attractive to call it, metastatic renal cell carcinoma, right? That you can go to that trap, right? Yeah. So, but it's not, right? Then they did a synaptophysin. That synaptophysin is diffusely strongly positive. The reason that PAX8 is known that PAX8 can be positive in pancreatic neuroendocrine tumor, actually in big proportion. I think it's almost like 60 or 70% of the cases. So this is one of that example. Another thing that it can go to another trap because it looks like the tumor cells look like adrenal cortical cells because of these microvesicles in the cytoplasma. When you look at the adrenal cortical, it looks like that. You can go to that trap. So if you do the inhibiting, it's positive. You can go to that trap to call it adrenal cortical neoplasm. Probably carcinoma because already metastatic. So that's a pitfalls. But if you do like a steroid factor 1, it will be negative. That's marker for the adrenal cortical adenoma. So this is, and based on that history, patient with hemangioblastoma, most likely the patient has one hypolindal syndrome. That's known that this patient will have a particular type of neuroendocrine tumor clear cell type. This is that type. So this is a very peculiar case that I have seen only one time. So it's, and also another differential that enters the differential diagnosis is hemangioblastoma. Very rarely hemangioblastoma has been reported in pancreas. So all these are in the differential. Actually, we also did the hemangioblastoma markers, which is also negative. So overall, it's a clear cell type pancreatic neuroendocrine tumor. And on top of that, we have another cystic structure next to it. What is that? This is a serous cyst adenoma, right? It's a serous cyst adenoma. You can see that it's low cuboidal cells, some of the clear cytoplasma. And I'm not sure, maybe some of them even have villi. So this is a serous cyst adenoma. This is a no combination for the one hypolindal syndrome, clear cell type neuroendocrine tumor versus serous cyst adenoma. This is case 5. Again, this is a patient with neuroendocrine carcinoma history. Now she has multiple masses. And this is normal liver parenchyma for sure. And this tumor very dark. Again, it's pretty nasty morphology, right? Uniform nasty morphology. In some areas, getting more bigger nests or even diffuse growth pattern. And again, we are talking about neuroendocrine tumor. You will go there. There are other differential diagnoses too. And we can see that this tumor is very tumor cells are pretty pleomorphic. But if you look at it carefully, I mean, it's hard to count mitosis for some reason because the cut. But when you look at all these nuclear debris, there are a lot of single cell apoptosis going on in the background. Of course, we will do the try to count the mitosis, but most importantly, we'll do KICD7. And this tumor is the patient has neuroendocrine carcinoma history, so of course we will do synaptophysin and pan-cytokeratin. All those are diffusely positive. I think the pitfall is grading. What to call? Is it a neuroendocrine tumor or is it a neuroendocrine carcinoma? That's my question. Because when we have this nested morphology, organoid morphology, we would go to the neuroendocrine tumor category. When we look at the KICD7, it's very, very high. Wow. Of course, it can be a significant overlap between the grade 3 neuroendocrine tumor versus neuroendocrine carcinoma. So this does not entirely exclude the possibility of a neuroendocrine tumor, But when you look at the P53, this one is pretty high, 50-60%. So this give a clue that this is a neuroendocrine carcinoma, especially based on the history. This is the metastatic neuroendocrine carcinoma. For some reason, when the neuroendocrine carcinoma was treated, they can become they can have a more bland cytology. They can have more organoid structure. This is known right now. So just a brief review of all the true neuroendocrine tumors, neuroendocrine neoplasms. They can be roughly divided to 3 categories: well-differentiated neuroendocrine tumor, poorly differentiated neuroendocrine carcinoma, subclassified to small, larger cells, and then meaning the mixed neuroendocrine, non-neuroendocrine tumor. This is based on the mitotic rate and the mitosis. I think the difficulty relies on the differential diagnosis between grade 3 and grade 3 neuroendocrine tumor versus neuroendocrine carcinoma. These two, one of them are neuroendocrine tumor, one of them is neuroendocrine carcinoma. At this point, I cannot tell for sure, actually, simply based on morphology. They are very similar. But the differential diagnosis is kind of important because well-differentiated neuroendocrine tumor has a much better prognosis and poor response to platinum-based therapy. So poor differentiated carcinoma has a very poor prognosis. However, they respond better to platinum-based chemotherapy. So differential diagnosis seems to be pretty important. So the MSK study demonstrated the markers, which can be useful for the differential diagnosis are the p53, RB, SMAD4, and the DAX-HX. p53 cutoff 25. It is more than 25. You favor neuroendocrine carcinoma. RB loss, SMAD4 loss are more common in neuroendocrine carcinoma. And the DAX-HX loss, however, is more common in the neuroendocrine tumor, 40% of neuroendocrine tumor. And sometimes these markers may not be helpful. So what do we do? Because these are all present or lost in certain percentage, not 100%, right? So if we have problems, we have to correlate with clinical findings. If it's grade 3 neuroendocrine tumor, usually the patient does not have any symptoms associated with high-grade malignancy. The patient usually have the elevated neuroendocrine markers, and they have diffuse avidity on octreotide scintigraphy. However, if it's a poorly differentiated carcinoma, the patient will have pretty bad symptoms, cachexia or whatever, and they can have elevated plasma carcinoma markers, CEA, CA19-9, those kind of things, and they will have negative or weak octreotide scintigraphy. This is a case that can, it's not a case of potentially pitiful. You can see that this is before treatment, the neuroendocrine tumor, neuroendocrine carcinoma. After treatment, it becomes much blander, much benign appearance, much organoid. You can simply call it, you can easily call it a neuroendocrine tumor. When you look at the KSD7, after treatment, it's very heterogeneous. In some areas, almost totally negative. We can imagine if you put your needle this way instead of that way, if you get these cells, you may call it a neuroendocrine tumor, right? And this is, however, what's helpful is RB. The RB is lost in the tumor. So this is the pitfall for treated carcinoma. So based on that, if the patient have neuroendocrine carcinoma previously, we are pretty sure about diagnosis. Now they have these metastatic tumor or whatever recurrence, they look much blander, much lower KSD7. We still refer to the previous diagnosis, saying that it's most likely metastatic neuroendocrine carcinoma, instead of giving a second diagnosis as a well-differentiated neuroendocrine tumor. This is a pitiful. And I just want to briefly mention that now the neuroendocrine tumor can be classified this way, based on infiltrative patterns. This is a paper published by Dr. Adsey, which is a king in the pancreatic pathology field. Based on, somewhat similar to the follicular adenoma of the thyroid. This is a tumor, this is a capsule. If it is very confined, it's super benign. If it is super infiltrative, that's malignant. These correlate. This is pattern 1 example, it's a pattern 5 example. You can see that the parenchyma is all destroyed by these neuroendocrine tumors. So this correlates better than the grading and the staging of the CAP. So this can be the future. However, it needs further validation. And now we finish looking at all the true neuroendocrine tumors, and then let's look at something that's mimickers, so-called mimickers. Here's a big tumor again. We have, this is the one I made a mistake on that I have to amend my report. Because we don't have trypsin halls. And then look at it. I know it's a kind of mixed morphology. In some areas it's acinar structure. However, in some other areas, it's becoming chordate structure. In cytology-wise, somewhat different. In the acinar structure, it's more mild, more blender cytology. In the cortical structures, or more malignant. Some of these areas more, micropapillary structure, but instead of acinar structure. I consider the possibility of acinar cell carcinoma components. However, because we don't have that in house, I did samplephysing that is diffusely strongly positive in the entire tumor, and I signed out as a neuroendocrine tumor grade 3 because Ki is 30% actually. Then later when I signed it out, I feel it's don't quite right, not without any suggestion by others. I sent it out, did a trypsin stain. Again, this kind of acinar structure, cortical structure, more malignant appearance. And the trypsin is diffusely positive in those components. Actually, those components occupies more than 50% of the entire tumor. So this is actually a more appropriate diagnosis. Should be mixed acinar neuroendocrine carcinoma instead of just a neuroendocrine tumor. That's a pitiful. Even the tumor is diffuse strongly positive samplephysing. It's better to have that in the differential diagnosis, especially when you have mixed morphology. This is a case 7. It's a retroperitoneal mass. Again, this is a neuroendocrine tumor in the retroperitoneal. Nested morphology, pretty rich vascular network. Somewhat clear, somewhat eosinophilic cytoplasma, very organoid growth pattern. And again, we see this random kind of pleomorphic cells, but we know that it's probably due to so-called neuroendocrine atypia. It's differential diagnosis. If a samplephysing positive, the differential diagnosis would be paraganglioma versus metastatic neuroendocrine tumor. Samplephysing, diffusely positive. Pancreatic negative. So that means this is most likely paraganglioma, right? And GATA3 is also positive. So this is, I just want to mention the usefulness of pancytokeratin. I always do a pancytokeratin stain in the neuroendocrine tumor, because when it's positive, it's in a neuroendocrine tumor, most likely neuroendocrine tumor. But if it's negative, then the differential diagnosis include a whole bunch. In addition to paraganglioma, adrenal cortical tumor can be negative for that. Solid residual papillary neoplasm, pancytokeratin can be negative or very focal. So based on the positivity and negativity of pancytokeratin, we kind of generate different differential diagnosis. This is this is the paraganglioma, and another important thing is for paraganglioma, now this SDHB, succinate dehydrogenase, is considered as a prognostic marker. This case happened to have loss of succinate dehydrogenase. So you can see that all these stromal or testicular cells are positive for or have preserved succinate dehydrogenase. However, the tumor cells actually have loss of succinate dehydrogenase. So this patient will have a higher risk of metastasis. So this is a 7.3 centimeter pancreatic mass in a 31-year-old. Again, I just want to make give a mimic of neuroendocrine tumor. This tumor will be diffusely strongly synaptophysing positive. It has this normal pancreas. You have like a fibrotic capsule, or even at this power, we can see that there are a lot of those cystic spaces filled with blood. And we go to this side, it's falling apart, right? Have that even at this power, you can see it's somewhat papillary. If they go to higher power, I mean, they're not true papillary, right? Because they don't have that, individual papillary structures. They are more like sheets of tumor cells with those fibrovascular cores. The tumor closer to the cores will be staying. However, the tumors away from the cores will be falling apart. So giving a feeling this is papillary, but it's not true papillary. And the tumor cells are kind of clear, eosinophilic, some bubbly. It's very bubbly appearance. This is a characteristic cytoplasmic feature of this tumor. And when you look at it more carefully, you can see that maybe here you can see all these hiding globules. It's not doesn't show very well in the scan size. has these hyaline globules, and cytoplasma-wise, sorry, nuclear-wise, they have kind of irregular nuclear membrane. Some of them are even, maybe have nuclear groove. So this is a classic example of solid pseudopapillary neoplasm of the pancreas. And again, this tumor will be most likely will be 100% synaptophysin positive. So make some of these cases, especially on cytology, can be diagnosed as neuroendocrine tumor. That's not a big mistake anyway. But on resection, when we see these features, don't forget solid pseudopapillary neoplasm. CD56 is also positive, and a whole bunch of other markers like TFE3, hormone, and androgen receptor, or not androgen, sorry, progesterone receptor will also be positive. And consistently, beta-catenin has nuclear positivity. So this is all consistent with solitary pseudopapillary neoplasm of the pancreas. The case 9 is 11.5 liver mass in a 64-year-old, otherwise healthy female. Well, this is a difficult one, and see whether you guys can name the diagnosis, because to me it was like an instant pattern recognition, because I have read about that. I haven't seen anything, but I have read about that. This is a liver tumor. It's very, very interesting. And look at it. It has these very bland cystic structures with kind of pink secretion, proteinaceous secretions. Very, very bland, almost like thyroid or secretory carcinoma of the prostate, right? You can go to that route pretty easily. These are very, very bland. But here it's getting more complicated. They have this confluent structure, cribriforming structure, globuloid, and now it's very, very cribriforming. But look at the cytology. The cytology is very bland and very uniform throughout the tumor. Here it's slightly different. It's slightly columnar instead of more cuboidal, more pseudo-stratified. When I look at this, I know that's the tumor I have looked at, but how do I think about that? I think we should go through the normal procedure. Firstly, whether it's benign malignant. I think even for that, it's hard to say. It's a big tumor. However, there is a benign tumor in the pancreas that a benign tumor in the liver that can have this morphology. What is that tumor? It's adenofibroma. That's definitely in the differential diagnosis. And also, we need to put it in the differential. We should think about the metastatic carcinoma, right? Metastatic carcinoma, particularly thyroid or kidney, or even metastatic carcinoma, metastatic secretory carcinoma from the salivary gland. And we did a particular stain that is albumin cytohybridization. That is diffusely positive. So suggesting this is a tumor of the liver primary. It's not something metastatic. And this is the resection. We called it favorite cholangiocarcinoma. However, in differential diagnosis, we said, adenofibroma could be in the differential diagnosis, but adenofibroma is considered as a pre-malignant condition. And also, it's actually controversial. Some people even think that adenofibroma is essentially a low-grade cholangiocarcinoma. So we get it resected. Border of the tumor to the liver is not very infiltrative. It's kind of zigzag, but it's still there's quite a border, quite clear border. And again, similar to the biopsy, we have these very dilated cystic structure, and also very an area of complicated structure with cribriforming. And the cells, no matter whether it's in the cystic area or solid area, they have similar morphology. And when we have this uniform morphology, of course, we will consider neuroendocrine tumor. We did the neuroendocrine marker, that is positive, not strongly positive, not positive in all the tumors. It's patchy positive. So, and also the stroma is kind of interesting because stroma is fibrotic, but also have some smooth muscle strands. So when we put all these together, what is that? This is a very rare variant of cholangiocarcinoma. It's cholangioplastic variant of cholangiocarcinoma. I think the name makes sense because it seems like these smaller glands are maturing to the bigger glands, so it's blastic. So it's cholangiocarcinoma, but it's cholangioplastic. So this is cholangioplastic carcinoma, and this tumor is characteristically positive for inhibin. This is inhibin. It's diffusely strongly positive. Somebody has did this inhibin studies on the tumor. It's really positive in other primary liver tumors. So this is the first case. It probably up to now it's not more than 20 cases reported. This is the cholangioplastic tumor. The problem with this tumor is it looks very bland because it can recur, becomes metastatic. That's the problem. So 1/3 of the patient one half of the patient actually get recur or metastatic and died of disease. So this is a pseudo bland tumor, but it can potentially be malignant. However, how to predict the clinical course, clinical behavior, we have no idea because these tumors are so rare. So then case 10, it's a not big tumor, 4 centimeter in a 36-year-old female. And this is that, normal colon here. Obviously, we have a, pretty dark, a pretty blue tumor. You can see it's highly infiltrative with sheets of tumor cells, angulated nests, whatever, and the surface is eroded. And you go to higher power, again, the stroma is very infiltrative, and the cells are monotonous. Somewhat semi-cohesive, somewhat plasmacytoid, but a pretty uniform appearance. And we see mitosis, apoptosis in the background, and we did pancytokeratin that's diffusely strongly positive. Then we did synthesizing that is positive too, diffusely positive, although not strong. So we signed out as a large cell, polydifferentiated neuroendocrine carcinoma, large cell type. That's how we did it, and we were wrong. Because the molecular came back as a Ewing's tumor, Ewing's sarcoma. Yeah, this is a no pitfall. We thought about that. That's why we did synaptophysin events diffuse strongly positive. We signed it out. But I just don't. When we signed it out, we have something in the mind that doesn't quite right because the thing that there's no pre-malignant thing. It's a very pretty young female. We have this tumor. I think the pitfall is that it's better to put it in a bigger differential diagnosis, bigger category, because if you don't know it's in the colon, if you forget all this, if you get this tumor blindly, you probably sign out the frozen section as small blue cell tumor. That way you will have all differentials in it, and you will not miss all these things. And we did come back and did NKX 2.2 and FLI1. They are positive in the tumor, kind of consistent with a Ewing's tumor. Now we know that Ewing's tumor can have, diffuse strong cytokeratin expression. For example, in the head neck area, there's a so-called adenomatous. Sorry, not adenomatous. What's that called? So that's a tumor. It's a carcinoma with diffuse strong squamous cell marker differentiation. P40, CK5-6 are all positive. Adenomatous carcinoma. So that's controversial. Whether those tumors actually respond to carcinoma therapy or will respond to sarcoma therapy is controversial, because when the tumor becomes carcinoma, maybe it will respond better to carcinoma therapy. That's something that we don't know, because now the neuroblastoma or factory neuroblastoma with extensive cytokeratin expression is considered as carcinoma. Actually, those patients respond better to carcinoma therapy. So that's something controversial and something that we should think about in the future. But this is a Ewing carcinoma with a diffuse strong aberrant cytokeratin expression. So essentially we have all the tumors with neuroendocrine marker expression, discussed right now. Here I'm showing some example of neuroendocrine-ish tumors. They look like neuroendocrine tumor, but they don't express neuroendocrine markers. But you can occasionally enter into the differential diagnosis of a neuroendocrine tumor. This is a stomach biopsy. This is a mucosa, and this is tumor. very bland looking, very uniform. Of course, neuroendocrine tumor will be in the differential diagnosis. If you see that in your finger, you probably don't have, problem diagnosing it. You will call it glomus tumor, simply based on the morphology. However, in the stomach, it's very rare, Sometimes you have to think all of that outside the box. You don't want to just, I'm looking at the stomach. I never heard of glomus tumor. Every glomus tumor has been reported. This is a glomus tumor. This very bland cytology and very vessel-rich architecture. So this is a glomus tumor of the stomach, and it's smooth muscle actin positive. Another mimicker is this case 12. Again, nested morphology, high NSA ratio, making you think of neuroendocrine tumor. However, when you look at it, they have these kind of basement material-like structures percolating through the tumor. In some areas, pretty prominent. When we have these pictures, we probably think about, if you see that in the head neck area, you'll probably think, this is either basaloid squamous cell carcinoma or adenoid cystic carcinoma. Of course, sample sizing for this case is negative. P40 is positive. NFib is positive. So this is a adenoid cystic carcinoma. We don't know whether it's metastatic or primary because we don't have enough history. And this is the last case is pretty difficult one. Is bears wrong diagnosis initially. This is again a gastric tumor, 10 centimeter, very big in a young male. It's schizo tumor cells in some area. It's kind of lobulated, nodular. When you look at the cells, it seems like biphasic, right? In some area, it's kind of loose. In some areas, it's pretty dense. In some areas, totally epithelioid. In the loose area, it's kind of edematous or maybe have stromal mucin. Very bland spindle cells, although it's pretty hypercellular. Then we have these epithelial nets. They have kind of peripheral palisading in the inside. They form these acinar structures with pink secretion. Again, we have this condensed area. They are not entirely epithelioid like that. Somewhat spindle, somewhat similar to the background, loose spindle cells. Biphasic tumor in the stomach. So what do we think about? Of course, we have to think about those common things. It's not just whatever smooth muscle tumor, neuronal tumor. We ruled out all of those. Nowadays we also have to think about the untrapped tumor. It can be ruled out by molecular. But this morphology is very typical for a particular entity. Pancytoceratin keratin, we see that in this condensed area, it's slightly positive. In the loose area, it's negative. Pancytoceratin, it's strongly positive in that true epithelial nests. And CD10 is positive. However, c-KIT is kind of wishy-washy, kind of weakly positive. This is one we initially can be easily diagnosed as just DOG1 is completely negative. However, the morphology is characteristic for gastroblastoma. So this is a fusion tumor. It's a tumor caused by fusion between MALAT1 and GLI1. And this one is GLI1. If we do immunostains, GLI1 would be positive. Now the GLI1 is commercially I'm not sure whether it's commercially available or not. It's available for the in the lab of the people who published the first paper. The patient the tumor has sonic hedgehog signaling pathway upregulation, and usually it's in the younger patient, but it can occur in up to 56-year-old. Initially, people think it could be benign. However, later on, they found some tumors actually become metastatic, especially to lymph node. So this is a classic example of gastroblastoma. With all that, I'm gonna conclude my presentation. Hopefully, you get something out. If you have any questions, feel free to ask.
Wenyi, this has been really good. There were a couple of questions that came in the chat while we were talking. Just to reemphasize the way you differentiate between solid pseudopapillary tumor and neuroendocrine tumors. What morphologic clues do you use, and do you always include beta-catenin in your panel?
Yeah, actually, it's on cytology or on the small biopsy, it's kind of difficult. But some of the clues you can look for are, bubbly cytoplasma, the kind of nuclear groove, and sometimes if you can see the hyaline globules, that'll be even more helpful. However, I do those panel approach. Nowadays, if I have a neuroendocrine tumor, I also include the Asner, Asner markers and also the beta catenin, just to avoid the traps, because I have been in that trap.
Yeah, it's great to learn from our mistakes, and that's kind of what expands our our panel that we use, the beta catenins and the trypsins and so forth.
Yeah. I had an interesting case conference with another professor. He actually just showed random pancreas tumors by morphology and asked us to guess what kind of tumor is that. So we almost like 50% of the time we are wrong. So he tried to emphasize the importance of a panel approach, instead of just single markers.
So you shared one case where you mentioned the CDX2 positivity suggesting potential intestinal origin, but oftentimes we know that TTF1, CDX2, PAX8, and so forth can be quite variable and variably positive.
Quite non-specific.
So when do you find it useful and when is it not?
I think it's mainly I have that hypothesis already. It's something I use to support that hypothesis instead of using it as a major diagnosis. That patient does not have any actual hepatic tumor, and that's the only tumor in the CDX2. It's kind of weakly positive. Essentially, I said it's compatible. I wouldn't use that to say that's definitely
Yeah, and the PAX8 positivity in some cases is also quite disturbing.
Yeah, exactly. It can be up to like 60%, 70%. So we have to have that in mind.
So any other questions from people listening? You want to unmute yourself and ask, or you can type your question into the chat. The recording of this, of course, will be available later today for those who may have joined late. It looks as though we have people from Southeast Asia and the Middle East and South America. I really appreciate everyone joining us and sharing in this very, very good discussion of the diagnostic issues as well as the potential pitfalls.
Yeah, if you have any interesting pancreatic tumor cases, feel free to share with us. I'm very, very interested in that. Thank you so much.
All right. Well, thank you everyone for joining us, and we will look forward to seeing you again next month. Thanks, Dr. Luo.
See you.